Welcome to Physicians Who Lead, the podcast where we sit down with physician leaders who are shaping the future of healthcare. Each episode, we dive into the real challenges facing our system today and hear directly from the physicians leading the way with innovation, resilience, and vision. If you want to understand how healthcare is changing and meet the leaders driving that change, you're in the right place.
Welcome to the Physicians Who Lead podcast. My name is Kevin Kirkpatrick, and we are here to talk with physician leaders about how to shape healthcare and move things forward. Today's guest is someone who's made the transition from clinician to executive leader and is now working at the University of Clinical Care Operations and Innovation, Dr. Rohith Saravanan. We're going to get into what it takes to lead inside a health system, balancing quality, physician engagement, and the growing role of technology. Dr. Saravanan is a physician executive and CMO with experience leading clinical strategy, quality improvement, and system-wide initiatives. He's someone who understands both the realities of frontline medicine and the complexities of leading a healthcare system. Dr. Saravanan, welcome to the show.
Thanks for having me, Kevin. Happy to be here.
Excellent. So let's start with your story. What pulled you toward leadership, and how did you realize you wanted to have an impact beyond the bedside?
Well, I started my career in family medicine, caring for underserved patients, and I loved direct relationships with patients. But pretty early on, I saw that many of the biggest barriers to good care had very little to do with what happened in the exam room. They were operational, structural, cultural, sometimes financial. Patients were being affected by access issues, workflow breakdowns, poor coordination, and systems that were not designed around their needs. That was the turning point for me. I realized I could keep helping one patient at a time, which is deeply meaningful, and I loved it, or I could step into leadership and help shape the environment in which thousands of patients receive care. That is what pulled me towards leadership. It was never about leaving medicine. I love patient care. It was about expanding the scope of services.
I've heard that from quite a number of physician leaders over the past. It seems that moving into leadership is a bit more of a mission-driven component than a specific strategic career development aspect and stuff like that. So do you think a leadership found you, or was it something that you planned on before that?
I would say it's a little bit of both. I did not start out saying I wanted a title. I started by raising my hand to say, let me help solve this problem. Over time, leadership opportunities kept finding me because I was willing to step into complexity, build teams, take accountability. At some point, I became intentional about developing myself for larger leadership roles because I realized healthcare needs more physicians who can bridge clinical care, operations, and strategy.
Excellent. You're sitting in a CMO seat now. What is something that people don't necessarily understand about physician leadership from the outside?
I think people underestimate how much translation the role requires. A physician leader is constantly translating across worlds. You're translating clinical reality to administrators, operational constraints to physicians, financial realities to frontline teams, and organizational priorities back into something that still feels ethical and patient-centered. From the outside, people may think the role is mostly meetings and decision-making. In reality, a lot of it is trust building, conflict navigation, making hard trade-offs without losing your integrity. The physician leader often sits in the tension between what is ideal, what is possible, and what is sustainable.
And it's almost like you read my next question. How do you balance clinical credibility with the operational and financial processes that come with running a system?
Well, first, I don't see those as separate conversations. Quality, operations, and finances are deeply connected. If your care is fragmented, your operations are inefficient, and your finances will eventually suffer. So if finances are unstable, you cannot invest in quality, people, or innovation. So the question is not which one wins. The question is, how do you align them? Clinical credibility, I think, comes from staying anchored in what care actually looks like on the ground and making decisions physicians can respect even when they disagree with them. Operational and financial discipline comes from being honest that resources are finite and systems have to perform. My job is to make sure that we are not making financially driven decisions that erode care, also not making clinically idealistic decisions that are impossible to sustain. So good physician leadership, I think, lives in the disciplined middle.
It's interesting. I've talked to a lot of physicians, both on the recruiting side and then with the podcast and stuff like that, that see a lot of physicians go into leadership roles without a lot of support, right? And it's why, as part of my team, we often, or always, align a physician coach with our placements so that, they've got some support going into the role. How have you navigated, the progression when sometimes there's not someone standing beside you or providing that development?
Yeah, I think your point is right. Many physician leaders are placed into roles because they're good doctors, but they're not given the infrastructure, the mentorship, and the development needed to succeed. That is a mistake. Leadership is its own discipline. You cannot just hand someone a title and expect them to navigate strategy, people, conflict, finance, and governance without the right support.
Yeah, it's interesting. I had a conversation with a chief medical officer, and he was saying that one of the things that was a transition for him was that, when you're a clinical physician, you are in the now, right? You're dealing with that patient in that moment, and then you're on to the next patient in that moment. Whereas then when you come into a leadership role, you have corporate projects that aren't turned around as quickly. So it's not like you can decide to implement Epic in one meeting, right? It's a multi-month process. How have you developed your perspective away from that in the moment to the longer cycle that leadership takes?
I think physician engagement is probably the primary way I've done it. And I think physician engagement starts with mutual respect, not performative respect, like real respect. That means involving physicians early, being transparent about the constraints, listening seriously to what they are seeing, and showing that their input leads to some action. The other key is physicians engage when they believe the organization is serious. If they
Mhm.
feel meetings are symbolic or their feedback disappears into a black hole, they disengage. So what works is closing the loop, reducing unnecessary friction, giving physicians meaningful roles in shaping care delivery rather than just asking them to comply with decisions that were already made. I think the most engaged physician cultures I've seen are built around trust and responsiveness and shared ownership. Physicians want to know that they're part of building something, not just being managed. That's how I've navigated it in the past, is primarily through physician engagement.
Yes, excellent. It's true because I've in surveying and stuff like that when we look at physician engagement and stuff, and some of the times when the response rates are the lowest, you have to investigate why are the response rates so low, and often it is this notion of you keep asking us for feedback, but then nothing happens with it, right? And I think that's the key, and that you mentioned directly is that there has to be a feedback loop and there has to be a result that's come from that feedback. Otherwise, people are not going to be engaged in it, right? And I've been working with dozens of organizations over the last few years trying to recruit, and it's to a search. The ones where the physicians are engaged fill faster and with greater retention when the physician engagement exists, right?
Yes, absolutely.
Medical officers are often focused on quality, right, as a key indicator of their impact and stuff like that. You've led initiatives around clinical quality and excellence. What is a change that you've implemented that actually moved the needle? And then secondly, why did it work?
One thing that consistently moves the needle is improving flow by creating shared accountability across disciplines rather than treating delays as one department's problem. So, like in many hospitals, there are throughput problems that get framed as an ED problem or a hospitalist problem or a nursing problem or a case management problem. I think this framing is flawed. Flow is a system problem. What works is getting the right people around the same data, creating a common operational language, establishing clear escalation pathways. When physicians, nursing leaders, operations, and case management are aligned around daily barriers, ownership becomes clearer and decisions happen faster. That improves patient experience, it reduces friction for staff, and supports better capacity management. It worked because it was practical, visible, and team based rather than theoretical.
Has there ever been a project that didn't work the way you
Yeah, what does not work is trying to force change from a conference room without enough frontline input. Another mistake is launching too many initiatives at once without operational follow through. In healthcare, people are already overwhelmed. If you introduce change without clarity, resources, and feedback loops, you create cynicism instead of improvement. I have learned that change management is not just about having the right idea, it's about sequencing, communication, and credibility.
Excellent. Excellent. And I think that the key that I see in a lot of healthcare issues really is, not to simplify it, but is really related to communication, right? And stuff like that. I mean, I see a lot of recruitment ads and, I've developed a lot of recruitment ads, but a lot of hospitals say they want physician engagement, but I haven't found a lot that have it. What have you found that actually helps improve engagement?
Yeah, I mean, I think we just talked about physician engagement a couple of minutes ago. The biggest mistake is, organizations sometimes confuse communication with engagement. Sending more emails is not engagement. Asking for feedback after decisions are already made is not engagement. Creating committees with no authority is not engagement. Another common mistake is treating physicians as a problem to control rather than a strategic asset to develop. When organizations do that, they lose most valuable leadership potential. And yes, you're absolutely right. In places, physicians are treated as adjacent to the system rather than integral to it. It can create issues, right? That creates transactional culture. If you want real performance, physicians have to feel like owners, not outsiders.
No, and it's interesting, and I've seen this in Canada and the US, where it's almost like there's two entities, right? There's the physician group and then the hospital group, and the relationship between the two of them is challenging. And I advocate a lot for I did a post yesterday about calling it a broken link, and a lot of it is trying to build structures and routines that allow communication and engagement between the two. Things that I think don't necessarily happen as much, as things like succession planning and leadership development for physicians, right? Like, we worry about progressing nurses into nurse management roles, into director roles, into VP roles. And a lot of hospitals have systems and resources allocated towards that, but we don't necessarily do the same thing, right, with physicians. So I think that's, an opportunity to look at, how can we grow the physicians so they remain for their career with the organization and continue to add value by adapting and stuff like that, right? One of the things I think that's new is, obviously things like AI and technology and stuff like that. Do you see AI as actually improving patient care, or is it just one more technology that's going to create noise?
AI improves care when it removes friction and improves insight or strengthens decision making in a way that clinicians can trust. Like good case examples include like synthesizing large volumes of information, identifying risk patterns earlier, supporting documentation workflows, surfacing actionable insights from clinical and operational data. Where AI becomes noise is when it creates more clicks, more alerts, more dashboards, or more theoretical capability without solving a real clinical or operational problem. Healthcare does not need more digital clutter. It needs tools that improve the signal to noise ratio. It has to be able to fit into the physician's workflow. My view is that AI should augment judgment, not replace it. The clinician must remain accountable. If the technology does not make care safer, smarter, faster, or more human, then it is not innovation. It is just novelty.
We've alluded to this a few times, and I will say this loudly on all my social media channels and stuff like that, but we don't really do a great job of developing physician leaders, right? What helped you the most as you developed as a leader?
Yeah, I think when I think about that, I think of three things that helped me the most. First is staying close to the front lines, even as my responsibilities expanded. Second is learning the business side of healthcare seriously, not just superficially. And third is seeking the right mentors and experiences that help stretch me beyond my comfort zone. I also think formal leadership training and development matters. Medicine trains us to diagnose and treat. It does not automatically train us to lead organizations, manage conflict, build strategy, drive transformation. Those are learned skills. Physician leaders need to invest in themselves the same way we invest in clinical excellence.
Yeah. And it's interesting because I do, when I talk to physicians that are interested in getting into leadership roles, I do kind of talk about parallel, achievement. One is, can you take an MHA or an MBA or change management courses, or what, or a bunch of different courses, and do the didactic learning. And the other piece is that mentorship piece. And I do think that organizations should invest in developing mentorship relationships so that people have those supports. In a lot of organizations, you report to the CEO, or maybe you report to the board, and what if your relationship with those people is what you're struggling with? Like, how do you can't learn how to manage interpersonal conflict through a book. I mean, it often takes having someone to talk to and stuff like that. Have you ever had a mentor that stood out above everyone else?
Yeah, I mean, without question, I've had several. And I've been very lucky that many of the mentors that I've worked with have helped steer my career in the direction that it needed to go, sometimes even when I couldn't see it going in that way. Through the nonprofit work that I did with Jericho Road and Dr. Myron Glick, through the business leadership that I saw with MASH Urgent Care, with Mark Punt, and through a hospital president who allowed me to sort of take the reins of which direction to take the hospital during COVID, because she was very secure in her position and was able to hand off to me and say, go ahead and take us where you think the hospital needs to go and support the community during this difficult time. Stacey Brown, all of those people, have been great mentors for me throughout my career.
Excellent. So I have 4 what we'll call rapid fire questions for you as we close out here. But what's one leadership habit you've built that's made the biggest difference?
I make time to stay connected with the front line. Leadership gets dangerous when you become insulated.
Excellent. The best piece of advice you've ever received?
Do not mistake your title for impact. Real leadership is earned in trust, not granted in organizational charts.
That's a good one too. So what is one thing healthcare leaders need to stop doing?
They need to stop confusing motion or movement with progress. Too many organizations are busy but not aligned. They need to recognize when there's a difference between just moving or moving in the right direction.
Now, what's one thing the same leaders need to start doing?
I think they need to start investing deliberately in physician leadership and building systems around accountability and trust and execution.
So I feel like those are a lot of interpersonal and strategies that we can apply to a lot of different aspects of leadership, right? So Dr. Saravanan, I really appreciate you coming on the podcast and sharing your perspective. We've had other conversations where you've told me more about your experience, and I could probably do an entirely different episode just on all of the different things you've done. I appreciate these conversations because I do believe that we need to support physician leaders and grow. And I think we also need to expose physicians to physician leaders so they can see what possibilities exist and get support along that way. So thank you for being a guest. I appreciate that. And I look forward to continuing to build a relationship.
Yeah, I appreciate it, Kevin. Thanks for having me.
All right. Thanks again, everyone, for listening to Physicians Who Lead. And I wish everyone a great day.